You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
Welcome back. In this second part episode about idiopathic HCM and HOCM, we will switch to focusing on the management and prognosis. We'll go over medical management, then talk about surgical intervention and percutaneous intervention. Let's start off with medical management. In HCM and HOCM, you want to avoid dehydration because it is preload dependent. You also want to avoid vasodilators because it is afterload dependent. The obstruction gets worse if there's more vigorous contraction, decreased resistance, decreased volume, and all of these occur with exercise. So, to decrease the obstruction, you want to avoid positive inotropes, avoid pure vasodilators, and avoid high dose diuretics. You want to decrease contraction, do increase the resistance, and do increase the volume. In HOCM, interventions that decrease afterload, such as ACE inhibitors, and preload, such as furosemide, will increase the LVOT gradient. Beta blockers, such as metoprolol, will decrease heart rate and contractility, decreasing the degree of obstruction. Non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, can be considered as alternative second-line agents. Disopyramide can be considered in refractory cases. When uptitrating medications for HOCM, look at how low the heart rate is to see if you can uptitrate the beta blocker, and look at the QTC to see if you can uptitrate the disopyramide if you are on disopyramide. HCM patients get the same long-term benefits from exercise, so you should not discourage HCM patients from exercise. If hypotension develops perioperatively in a patient with HOCM, prioritize intravenous fluid administration to correct hypovolemia. Use alpha agonists such as phenylephrine or vasopressin rather than beta agonists, which can worsen LVOT obstruction. Consider intraoperative echocardiography to evaluate LVOT obstruction in the setting of hypotension. In select cases, intravenous beta blockade may be necessary to reduce LV myocardial contractility and relieve LVOT obstruction. Now let's take a deep dive to the latest, most interesting medication called mavacamten. Mavacamten, which goes by the trade name Camzyos, is a small molecule reversible allosteric inhibitor of cardiac myosin ATPase. Specifically, mavacamten inhibits the rate of phosphate release from beta cardiac myosin S1, the rate-limiting state in the myosin cycle. Mavacamten also reduces the number of myosin heads that can enter on actin, that's power-generating states, and reduces the probability of formation of myosin-actin cross bridges. The result of these actions is that mavacamten shifts the myosin population towards an energy-saving, recruitable, relaxed state. Advanced medical therapies for HCM, other than disopyramide, are the mavacamten, which decreases the LVOT gradient by 36 millimeters of mercury. Disopyramide decreases the LVOT gradient by 35 millimeters per mercury. So they're both pretty effective. Mavacamten is given as once daily. Disopyramide is given TID 3 times a day. So it is a little bit more inconvenient for patients. Disopyramide causes dry eyes, dry mouth, and urinary retention. Mavacamten causes dizziness in 1 in 5 patients. Based on the way the trials were done, specialty pharmacists will only dispense 35 pills of mavacamten at a time. Patients on mavacamten need an echo monthly for the first 3 months, then every 3 months for the first year, totaling 7 echoes in the first year. In the subsequent years, the echo has to be done every 3 months, totaling 4 echoes per year. In patients in whom you are prescribing mavacamten, if the LV ejection fraction is less than 50% at any visit, or patient experiences heart failure symptoms, mavacamten treatment should be interrupted. Avoid co-administering mavacamten with disopyramide in combination with verapamil or diltiazem due to risk of worsening LV systolic function and heart failure symptoms. There is no dose adjustment needed for hepatic or renal adjustment in mavacamten. Medications for HCM should only be prescribed if there are symptoms, not because of the presence of HCM itself. Success in medical treatment in HCM is determined only by patient report. If they feel better, that's good enough. There's no need for ablation or myectomy if the patient already feels better. If a HOCM patient continues to have symptoms despite a beta blocker, calcium channel blocker, and disopyramide, as well as mavacamten if available in your region, then it is time to do septal reduction therapy, which refers to either surgical myectomy or alcohol septal ablation by the transcatheter approach. To recap medical management, let's see what the guidelines say about HOCM's medical management. According to the 2024 AHA-ACC guideline for the management of hypertrophic cardiomyopathy, in patients with obstructive HCM and symptoms attributable to the LV outflow tract obstruction, non-vasodilating beta blockers titrated to effectiveness or maximally tolerated doses are recommended. That's a class 1 recommendation. In patients with obstructive HCM and symptoms attributable to the LV outflow tract for whom beta blockers are ineffective or not tolerated, substitution with non-dihydropyridine calcium channel blockers such as verapamil or diltiazem is recommended. That's class 1. For patients with obstructive HCM who have persistent symptoms attributable to LV outflow tract obstruction despite beta blockers or non-dihydropyridine calcium channel blockers, adding a myosin inhibitor or disopyramide in combination with an existing atrioventricular nodal blocking agent or septal reduction therapy performed at experienced centers is recommended, class 1. For patients with obstructive HCM and acute hypotension who do not respond to fluid administration, intravenous phenylephrine or other vasoconstrictors with an inotropic activity, alone or in combination with beta blocking drugs is recommended, class 1. For patients with obstructive HCM and persistent dyspnea with clinical evidence of volume overload and high left-sided filling pressures despite other HCM GDMT, cautious use of low-dose oral diuretics may be considered, class 2B. For patients with obstructive HCM, discontinuation of vasodilators such as ARB, ACE inhibitors, dihydropyridine calcium channel blockers, or digoxin may be reasonable because these agents can worsen symptoms caused by dynamic outflow tract obstruction, class 2B. For patients with obstructive HCM and severe dyspnea at rest, hypotension, very high resting gradients exceeding 100 millimeters of mercury, verapamil is potentially harmful, class 3 harm. In addition, the 2024 AHA-ACC guideline for perioperative cardiovascular management for non-cardiac surgery, this is different from the other 2024 guidelines I mentioned, has one recommendation related to HCM. For patients with hypertrophic cardiomyopathy undergoing non-cardiac surgery, factors that aggravate or trigger dynamic outflow obstruction, such as positive inotropic agents, tachycardia, or reduced preload, are harmful and should be avoided to reduce the risk of hemodynamic instability. That's class 3 harm. Now let's move on to the second part of this episode, management and prognosis in terms of surgical and transcatheter treatments. General eligibility criteria for septal reduction therapy, which can be surgical or transcatheter, are clinical, hemodynamic, and anatomic. What does clinical refer to? Severe dyspnea or rest pain, usually New York Heart Association functional class 3 or 4, or occasionally other exertional symptoms such as syncope or near syncope, when attributable to LV outflow tract obstruction that interferes with everyday activity or quality of life despite optical medical therapy. That's clinical eligibility criteria for septal reduction therapy. Hemodynamic criteria: dynamic LVOT gradient at rest or with physiologic provocation with appropriate approximate peak gradient of at least 50 millimeters of mercury associated with septal hypertrophy and systolic anterior motion of the mitral valve. That's hemodynamic criteria for eligibility for septal reduction therapy. And how about anatomic criteria? Targeted anterior septal thickness sufficient to perform the procedure safely and effectively in the judgment of the individual operator is needed. Other indications for septal reduction in HCM are as follows: drug therapy not working, not tolerated, or not desired. So the patient preference has a big role in this matter. Next, other need for cardiac operations, such as a concomitant CABG or valve surgery. And next, signs of deterioration, such as worsening pulmonary hypertension, recurrent paroxysmal AFib, or severe exercise limitation. These are other indications that will push you towards septal reduction in HCM. Surgical myectomy is more customized towards the patient's specific anatomy than ablation, but myectomy requires a sternotomy, takes weeks to return to activity instead of days, and causes more pain to the patient. 30-day mortality is 1% for both procedures. 30-day risk of adverse complications such as tamponade, LED dissection, infection, and major bleeding is 5% for both procedures. 30-day risk of complete heart block requiring permanent pacemaker is 10% for ablation, significantly higher than the 5% for myectomy. Repeat procedure is needed in 10% of ablation patients and 3% of myectomy patients. In terms of success and outcomes, in both ablation and myectomy, more than 90% of patients have symptomatic improvement of at least one NIHA functional class, and more than 90% of patients achieve a rest and provoked LVOT grade in under 50 millimeters of mercury. When alcohol ablation is performed for HCM, alcohol is injected into a septal perforator artery, usually the first septal perforator, to create a localized infarct, which will cause subsequent thinning of the proximal septum and consequent reduction in LVOT gradients. Prior to injecting alcohol, contrast opacification should be done to localize and quantify the area about to be infarcted. You want to see contrast opacification at the site of the mitral valve systolic anterior motion septal contact, which is at the proximal septum. If your contrast opacification occurs at other territories of the heart, such as the mid portion of the ventricular septum, inferior wall, RV wall, or moderator band, then it is a bad idea to inject alcohol into that septal perforator. You either have to find a different septal perforator to inject, or you have to abort the alcohol ablation. Transaortic septal myectomy is performed a placement of the scalpel through the aortic valve, which can be complicated by injury to the aortic valve cusp and resultant aortic regurgitation. Myectomy may alter the subvalvular apparatus, such as resection of the papillary muscle myocardium or accessory cords, but it should not result in mitral inflow obstruction. Residual obstruction, either at the LVOT or mid-ventricular level, can occur even after intervention. If too much myocardium is resected, an iatrogenic VSD can be caused. Alcohol septal ablation can cause a right bundle branch block in 50% of patients. So, if the HOCM patient has left bundle branch block at baseline, alcohol septal ablation will result in complete heart block, so you should do surgical myectomy instead. To recap, let's see what the guidelines say about surgical and transcatheter management for intervening in HOCM. According to the 2024 AHA-ACC guideline for the management of hypertrophic cardiomyopathy, in patients with obstructive HCM who remain symptomatic despite GDMT, septal reduction therapy in eligible patients performed at experienced HCM centers is recommended for relieving the LV outflow tract obstruction. That's a class 1 recommendation. In symptomatic patients with obstructive HCM who have associated cardiac disease requiring surgical treatment, such as an associated anomalous papillary muscle, markedly elongated anterior mitral leaflet, intrinsic mitral valve disease, multivessel CAD, or valvular aortic stenosis, then surgical myectomy performed at experienced HCM centers is recommended. That's class 1. In adult patients with obstructive HCM who remain severely symptomatic despite GDMT and in-home surgery is contraindicated or the risk is considered unacceptable because of serious comorbidities and advanced age, alcohol septal ablation in eligible patients performed at experienced HCM centers is recommended. Now, how about surgical myectomy performed at earlier stages of symptoms? So they say in patients with obstructive HCM earlier, meaning NIHA class 2, surgical myectomy performed at comprehensive HCM centers may be reasonable in the presence of additional clinical factors, including the following. And this is a class 2B recommendation. Severe and progressive pulmonary hypertension thought to be attributable to the LV outflow tract obstruction or associated mitral regurgitation. Left atrial enlargement of at least one episode of symptomatic atrial fibrillation, or poor functional capacity attributable to LV outflow tract obstruction as documented on treadmill exercise testing. For symptomatic patients with obstructive HCM, septal reduction therapy in eligible patients performed at experienced HCM centers may be considered as an alternative to escalation of medical therapy after shared decision making, including risks and benefits of all treatment options. Class 2B. For patients with HCM who are asymptomatic and have normal exercise capacity, septal reduction therapy is not recommended. Class 3 for harm. For symptomatic patients with obstructive HCM, in whom septal reduction therapy is an option, mitral valve replacement should not be performed for the sole purpose of relief of LV outflow tract obstruction, since this is a secondary mitral valve regurgitation. This is class 3 harm. In this last section, we'll go over ICD and the role of ICD placement in HCM. Features of HCM associated with increased risk of sudden cardiac death are LV wall thickness more than 3 cm. That itself is an indication for ICD. LA volume, presence of apical aneurysms, a dilated hypokinetic phenotype, which is the end stage or burned out stage of HCM that occurs in 5% of HCM, a restrictive filling pattern, which is seen in 2% of HCM, and degree of LVOT obstruction, especially if it exceeds 30 millimeters of mercury. LVOT obstruction exceeding 30 millimeters of mercury is associated with higher incidence of sudden cardiac death, HCM-related death or death from any cause, progression to New York Heart Association 3 or 4 symptoms, or death from heart failure or stroke compared with non-obstructed patients. In HCM, the thickness of LV hypertrophy is associated with sudden cardiac death in a linear manner. That is why HCM patients should get a primary prevention ICD if LV wall thickness exceeds 30. If a HCM patient has already experienced sudden cardiac death, VFib, or sustained VT, ICD placement has a class 1 indication. In the absence of that, an ICD is reasonable, that's class 2A, if there is at least one of a family history of sudden cardiac death in a first degree relative under 50 years of age or multiple secondary relatives, massive LV hypertrophy at least 30 millimeters in thickness, arrhythmogenic syncope in the last 5 years, LV apical aneurysm or LVAF of 50% or under. These are the factors where an ICD placement is reasonable, even in the absence of sudden cardiac death or VFib or sustained VT. Next, an ICD may be considered, that's a class 2B level recommendation, if there is non-sustained VT on Holter or extensive late gadolinium enhancement, more than 15 to 20% in the LV wall on CMR. An ICD is not indicated, class 3, in all remaining cases. Can athletes with HCM participate in competitive sports? According to the AJACC 2024 guidelines on the management of HCM, the answer is basically yes. They say for most patients with HCM, universal restriction from vigorous physical activity or competitive sports is not indicated. Class 3, no benefit. For patients with HCM, mild to moderate intensity recreational exercise is beneficial to improve cardiorespiratory fitness, physical functioning, and quality of life, and for overall health in keeping with physical activity guidelines for the general population. In individuals who are genotype positive, phenotype negative for HCM, participation in competitive sports of any intensity is reasonable, class 2A. For patients with HCM, participation in vigorous recreational activities is reasonable after an annual comprehensive evaluation and shared decision making with an expert professional who balances potential benefits and risks. In patients with HCM, ICD placement for the sole purpose of participation in competitive sports should not be performed. That's associated with class 3 harm. That's all for this episode on the management and prognosis of HCM and HOCM, including medical management, surgical and transcatheter therapies, as well as ICD placements.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.